Today, we're joined by Andrew Wickline. Dr. Wickline practices in New Hartford, New York. He went to Albany Medical School for med school as well as residency, and then he did a total joint fellowship at the Cleveland Clinic. So welcome, Dr. Wickline.
Hey, thanks for having me.
You're welcome. So I wanted to talk to you specifically because you are someone out there doing kinematic alignment. I have seen videos of you talking about it, as well as, if we have time, I'd like to touch on your therapy-free protocol for post-op. But I want to talk with you about your experience on KA. How did you initially get interested in kinematic alignment?
So I've been in practice for 20 years. I do about 550 knees a year. I've done, and then about 300 or so hips a year. So, in my mind, KA is kind of like it's like what anterior hip was, a decade ago. So I think you see across the nation, a lot of people are talking about, KA and, their versions of it and so forth. I got into it basically because I live in a small town. I can't escape, patients that have persistent swelling or take longer to recover. And so I started to ask myself, what's wrong here and what can I be doing better? I think the key case that really made me feel that there was something wrong with my computer navigated mechanically aligned knees was the isolated patellofemoral patient, right? So here's a patient that you think, oh, it's a slam dunk, 71-year-old female, thin, great medial lateral stability, just isolated patellofemoral, maybe one small lesion of the lateral condyle. This is going to be an easy case. And, I put the computer nav pins in, I do all my stuff, and boom, boom, boom. Okay, 30 minutes, got the trials in, and holy cow, it's really sloppy, medial to lateral. What happened? And it's really because I didn't place the parts where her native alignment was. I did something that I made her fit into this mold that we think every patient should be in. So that's kind of the key case that made me think KA, or maybe look, is MA the right answer? And then I saw this crazy slide that shows only 4% of the population has a zero hip knee ankle angle. So that means out of 8,000 computer navigated knees, I only hit the target 4% of the time. So I got it wrong 7,560 times. So
that's a humbling number.
I did that and I said, oh my God.
Yeah. So were you seeing that 20% that people are talking about of patients that aren't totally satisfied with their total knee?
I don't know if it's 20%. I wasn't keeping amazing data at that time, but my gestalt was there was certainly at least 10%, maybe 15%. If you operate on people who have horrific knees, you could put the knee in backwards and they're going to be relatively happy, right? It's those patients it's that 57-year-old with grade 4 medial compartment and grade 3 patellofemoral. You put a knee in for that patient and you miss the mark a little bit. They're highly active patients, and they're going to complain, and you are going to have to listen to it forever. So again, I think those are the patients. I don't know what my percentage was, but I knew I could do better.
Right. Well, even as is the average age of a total knee replacement patient today is significantly younger than when I started in the industry 30 years ago. I mean, when I started, it was upper 70s, and I'm willing to bet now that the average age is somewhere low 60s. And
I would agree with that.
Expectations are significantly different. As you said, with people waiting longer back then, you could put in the knee, you would have room for error because pain relief was their biggest issue. It was not function.
And I would say 30% of our practice back then was rheumatoid arthritis patients. The new biologics, you just never see those patients anymore.
Yeah. So I talk with a lot of orthopedic surgeons that are thinking through kinematic alignment, and they're kind of scratching their head because as we talked beforehand, kinematic alignment could be slightly different to everybody, just as anterior hips, everybody does an anterior hip probably slightly different, or there's multiple variations out there. How would you describe kinematic alignment to people?
So I guess I like to keep things kind of simple, right? So what you take out is what you put back. And so when you do mechanical alignment, you usually get a tibia, medial side tibia
Mhm.
is this big, and the lateral side tibia is that big. But the plastic you put back is like this,
Correct.
right? So right out of the gate, you know something's not right. And so that's what really ultimately appealed to me about the caliper kinematic technique, because I mean that makes sense. You're trying to put the tissue back to its native origin. Yeah, maybe that alignment only got that patient 62 years, but they're not living to 160, so it's probably the right answer. And I never have to touch the MCL now. Um, and we know that in the NFL, if you have an isolated ACL tear, you can get back to play in about 4 months. It, uh, when you combine MCL with ACL, 10 months average to return to play. So what are we doing with a total knee? It's an ACL, PCL, MCL injury, and sometimes some pie crusting laterally, and it's crazy. We're destabilizing the entire knee, and then we can't figure out why it's swollen, why the patient doesn't like us.
Yeah. So let's jump into your technique on how you do a total knee. You've mentioned navigation. Do you currently still navigate?
No,
No, you're doing everything mechanically.
no, I'm doing everything with the single-use instrumentation
Okay.
using calipered kinematics. So, again, I estimate, I remove the cartilage on the medial side and estimate that to be 2 millimeters plus the saw blade and so forth, right? It's Steve Howell's technique. And same thing with the tibia. We try to make equal resection on both sides, understanding there's some cartilage loss on one side or the other typically, and taking into account for that. Um, I have done the patient specific guides. I like those. I think that potentially might be the way I switch my practice as the next step. But I really wanted to learn how to use the jigs from that system,
Mhm.
so that if the whatever, if the femoral a jig falls on the floor, it's no longer sterile. I need to know how to get out of trouble. So
Correct.
I got about 2,000 cases using the single use instrumentation, um, and I feel confident that if I go down a different route, whether it's augmented reality or PSI jigs, if something fails, I can fix the problem.
Right. So questions that I have, because I have not seen kinematic alignment in my area. Um, if you're doing a normal total knee, femur first, drilling a hole and putting your rod up there, 5 degrees is what you're assuming you'll be in valgus. And then your guide is hitting the most prominent part on your distal femur, and you're taking 9, 10, whatever you're setting the depth to off that, correct? How are
Yeah,
you accounting for that? Because you're wanting, if your prosthesis was 9 millimeters thick, you're wanting to replace 9 medial and lateral, correct?
correct.
And so how are you accomplishing that?
So with the standard instrumentation, you place a rod inside the femur, and then there's a jig that goes over the top of that rod, just like in your set with a distal femoral
Yeah.
resection guide. That jig has 2 millimeters to represent the thickness of the cartilage on whichever side is diseased. So it's thicker on one side. So if you have a patient with a typical varus knee where all the cartilage is gone immediately, there might be still some left, so you have to scrape a little bit away sometimes. But now that jig sits directly on the bone, and the other jig sits directly on the cartilage on the generally intact lateral femur, and so it lies directly on that surface. And so when you make the cut, you want 9 millimeters. It's going to give you 6 medially. It's going to give you 8 laterally, plus a millimeter of saw curve. That gives you 9 and 9.
So your instrument is specially made for rest on a disease side that has all the cartilage gone, and then it has that two
Correct.
millimeters built in it, so it's offset.
Correct.
Big. Yeah.
So there's one for valgus. They'll come in the tray. One for valgus, one for a varus, and one for both
Yeah.
sides.
Right. So typically, are you doing the femur, going right to the femur, doing all of that, and then going to the tibia?
So that's the way that Steve does it. I don't. I have trouble get. I don't know. I have a lot of men with these huge saucer patellas. So sometimes I have trouble getting the kneecap out of the way to get the jig underneath the lateral condyle. So I'll make the distal femur, proximal tibia.
Mhm.
Then I check my gap, make sure that my typically a varus cut of the tibia is appropriate. There's no opening on either side. So now I know that I'm good for my tibia. And now I go back to the femur, finish the femur. Again, the one key with kinematic, you definitely want to look at the patellofemoral articulation and the trochlea. So I think the knees that I've seen and that other surgeons talk about, I do believe in this whole 6 phenotypes, right? And I definitely think that valgus knee, significantly valgus knee with a high riding lateralized patella, that one's still problematic for me. Now, Steve and some of the people who've done this longer have some tricks up their sleeves to still do this from a KA standpoint. That patient, I will do MA still, and it seems to do very well. But I will tell you that you know um, that's kind of the way that I look at it.
Right. And then the big question I have on the femur: how do you set external rotation? Well, how do you get equal cuts on both sides? Because the condyles, posterior condyles, what I'm used to seeing are you taking off a bigger chunk on one side than the other.
The posterior side, you say?
Yes,
Posterior
posterior.
kind of. So yeah. So again, I don't do that. I take a 0 degree on both sides. So and that's I'm replacing what the patient started with. The
Yes.
key is if you make the correct tibia cut correctly, you don't need that external rotation. Now, rarely you might want 1 or 2 degrees, when you look at the cartilage loss and stuff. But in general, like I'm not sure you have to see it. Like really,
Yeah.
I invite you or anyone else who wants to come spend a day with me in the OR. I'm happy to take questions. You can see, you can feel the stability for yourself. It's crazy the difference. It's amazing the difference.
Yeah.
But
And
but
then
it's 7 and 7. After you make the cut, we measure and it needs to be 7 and 7 because the posterior on the implant that I use is 8 millimeters.
right, and you're accounting for about a millimeter
A
of
millimeter saw curve.
yeah. Okay. And then describe how you do the tibia, because you're
So
not
the
lining it
tibia,
up at the ankle like
that's
you would
correct.
with a
Totally
perpendicular
correct.
cut.
So again, it generally kind of, and that drop rod will generally aim towards the lateral malleolus, somewhere in that region. Oh man, in the first 400, 500 cases, oh God, it was really challenging to do. And then you would look at the X-rays and you say, oh boy, I don't know about this. But you go see this patient that you can actually see patella contours with minimal swelling at 2 weeks and at 6 weeks. That is and they're happy.
Mhm.
um, you don't see the pes anserinus problems, the distal iliotibial problems, because you got the joint line instead of, like this, you have it the way it's supposed to be. You know, when you
Right.
measure it pre-op, I mean, like I never, as a resident, no one ever really talked to me about this. They said, this is how you do a total knee and end of story. And no one really talked about where the actual joint line was. So
Right.
I didn't know any better.
And you briefly mentioned earlier that Dr. Howell does it on all comers. What is your threshold? I mean, if you have a huge valgus, are you
So
doing?
a bad valgus knee with a high riding lateralized patella, I will do mechanical because I know I can put parts in that the patient will be happy with, and I won't have patellofemoral problem. So I do think that that's one group that we need to do a little more research on.
Mhm.
I don't, just like I don't think we should treat everyone with, everyone should not get a 0 degree
Yeah.
hip knee ankle angle, because the data shows that's not the way the data is, right? So why should we treat varus knees exactly the same as valgus knees? Maybe they are two different disease entities. I do think that we might want to consider maybe having, you know, 2 or 5 or 6, different, subsets, that here's the protocol for this patient to get the best possible outcome and get the implants to work the best for that patient. So I stay those bad valgus with a high riding lateralized patella, I will do mechanical still. I know the other guys who are doing KA longer than me are, have different thoughts on that, and I'm just not quite there yet.
Right. Well, like everything, it's a process, right? Um, we talked briefly about your therapy or physical therapy free approach as well. Do you think that the KA aspect has helped you with this as well for your patients?
Absolutely. The key, you know, um, Patrick Ewing said, when will I return? When all the pain is and swelling is gone, right? So that's the key. We have to get swelling out of the joint. The knee doesn't bend well when it's swollen. It feels tight. We all know that. We know that when the lower leg is swollen, you have pain and discomfort. So it's all about controlling swelling. So, again, I live in a small town. The patients who went and did a 90-minute workout, twice a day in the inpatient rehab had double the manipulation rate, had double the narcotic use, unhappy compared to these patients who live up north who don't have access to therapy. They did my 4 simple exercises, and they didn't let someone torture them for 90 minutes because the poor therapists feel like that's what we want them to do,
Right.
And so it's something. What happened is because there's no pay for the surgeon the next 90 days, the surgeons have abdicated responsibility for that 90-day of rehab. And that's where there's so much that we can do for patients. So KA plus a medial pivot, in my mind, fixes anterior posterior instability, fixes taking down the MCL, so it creates way less swelling, makes a more natural range of motion. Again, putting the joint line where it belongs, gets the ligaments out to tension the best and the most reproducibly. It also decreases tibial loads. Meningini's work. So if he's a competitor to Howell, he has his own implant, right? Meningini's work shows that compared to gap and balanced resection versus measured resection versus KA, tibial loads markedly lower, right? So other researchers, everyone gave Steve a hard time for many years, but other surgeons who are competitors are seeing the same thing. This is here to stay, just like direct anterior.
Yeah. Well, and that's just like anything, is the true innovators, people are going to, cry that they're heretics at first because they're doing it differently. They're doing it differently than people are used to.
They laughed me out of AUKUS one year because I got up and said, my patients use very few pain pills. I don't use any therapy. They told me to sit down until I had a paper. So I published a paper, 386 patients, 86% use no therapy, or 85% use zero therapy, 86% 10 pills or less. That's the lowest in the nation.
Right.
It works.
That's amazing. And would you say that a big part of this also is your pre-op education of the patients, telling them this is what to expect day 1 or day 2, et cetera?
See, here's a book from a patient. Here's another book from a patient. All my patients, I get like 98% compliance, and they fill this stuff out. Let's see here. It's just crazy.
So you give them a workbook to go through and mark down. I did it.
Yeah. How many steps they should do, what they should do every single day. You can see that they've got the marks in the book. They fill it out every day. It tells them exactly what to expect. They make fun of me because they'll say, Wickline, you were off by 4 hours on day 17,
Right. Well, it's funny, and you have them handed into you as their homework.
Yeah. It's but that's patient engagement, right?
Right.
Craig McAllister and Swiftpath really said it best, that patient engagement, it's like if you want to win the Super Bowl and you're the coach, do you go in and you don't tell the quarterback, you don't teach the quarterback the plays, make sure the quarterback understands the plays,
right,
you're going to lose. So you got to teach the patient, who's your quarterback, how to win this game.
Right. And then the accountability expectation that you have of them at the end, that's amazing too, because we do want to be held accountable to things. And so that is awesome to hear. Dr. Wickline, you mentioned earlier that if anybody would like to come visit you, see how you do it, you're open to that.
Oh yeah.
What is the best way for people to contact you?
So Probably through my email. It's a Wickline, AWICKLINE 23 at gmail.com. I've had 3 surgeons out this month. I'm happy to. I like to visit other surgeons. When surgeons come in to visit me, to me, I'm happy to show you what I'm doing, but please critique me. Show me how I can do
Right.
better. Because I find that I've operated with so many different surgeons now. Unfortunately, some of them, they just feel like I'm the best, and you have to look at yourself as always second best, because that means you got room to improve. You know.
Yeah.
So you're welcome. I'm
Yeah.
happy to have people come out. We can make arrangements. Of course, you have to have get cleared by the powers
Right.
that be. But
Correct.
yeah, we have a lot of fun having surgeons come out.
Well, I appreciate that. And one of the things that I truly admire about the orthopedic surgeon that I interact with is on the surgeon side in the orthopedic industry, people are up there sharing their best ideas, practices, et cetera. So you learn. Where a frustrating thing for me is on the industry side, we're very company specific, not wanting to share with
Yeah,
everybody to help the
agreed.
profession along. So I truly appreciate that. And Dr. Wickline, I appreciate your time and helping me understand kinematic alignment a little bit better. And I hope to talk to you again soon.
Yeah, I'm welcome to have you come out so you can see it in person. No problem at all. Just shoot me an email. Thanks for having me.
All right. Thank you very much. Have a good night.